Hello, everybody. This is Professor Ghulam Siddiq. Today, I got a very interesting case. That's a 70 years old lady who presented to our outpatients clinic with 3-4 weeks history of increasing constipation associated with vomiting. She is a known case of large hiatal hernia, which she had for more than 10 years, and that was associated with discomfort in her lower chest and associated dysphagia at times. We investigated her thoroughly, and her CT scan of abdomen and pelvis revealed dilated small gut loops with a transition point at the level of distal ileum. Now, this lady has had a hysterectomy done in the past. She was hypertensive. An echocardiogram revealed the ejection fraction of 55%, though she had calcified mitral and aortic valves. We booked her for diagnostic laparoscopy with the aim of Nissen fundoplication and possible adhesiolysis. I thought the subacute obstruction, which was going on for more than 3 weeks, was probably secondary to adhesions from her previous surgeries. Diagnostic laparoscopy revealed dilated small bowel loops. There were minimal ascites in the pelvis. Some adhesions in the lower abdomen were divided. In the pelvis, terminal ileum was herniated into a segment of peritoneum in the pelvis, and this segment of the ileum was densely adherent to what was described as a dilated vaginal stump. This pocket of peritoneum was then released to make a good access to the deeper part of the pelvis. Looking at her age, this area of the pelvis was looked for any underlying malignancy, and there was no evidence of any primary or metastatic tumor in the pelvis. After release of the herniated small bowel and division of adhesions in the pelvis, we moved to the upper part of the abdomen. Surprisingly, a small nodule, which was not picked up by the CT scan, was noted on the anterior surface of the abdomen. This looked like an exophytic gist, but still we had to do a frozen section on part of this tumor, and the frozen section confirmed this to be most likely a gist rather than a malignant neoplasm. The hiatus hernia was then addressed by incising the peritoneum medial to the right crest of the diaphragm, getting into the hiatus. Hernial sac was dissected out. Posterior vagus nerve, the anterior vagus nerves were identified and preserved, and about 4 centimeters of intra-abdominal segment of the distal esophagus was achieved. The fundus of the stomach was then mobilized by dividing all the short gastric vessels. Cruroplasty was next performed using an ethibond suture. Care is taken here not to make the hiatus too tight. I always test this by passing a minimum of 40 French bougie to make sure there is no resistance. The nodule on the anterior wall of the stomach, which was supposed to be a gist, is next excised with a good margin of clearance, or an R0 resection was performed using a linear stapler. The stapler was fired in horizontal fashion to make sure that the lumen remains wide open. These are some stay sutures which I placed all around the tumor. The bougie here passes without any resistance, as it can be seen. Floppy fundoplication was then performed. The same ethibond suture is used here. I usually place 3 to 4 sutures, and one or two of these sutures would incorporate a small bite from the anterior wall of the esophagus as well. The sutures are then tied over the bougie to make sure that it doesn't become too tight. Now we went back to the pelvis to see if the dilated segment of bowel, which had fecal contents in it as reported on the CT scan, were passing through the stricture or not. In fact, the distal bowel was still collapsed, and despite laparoscopic efforts, it couldn't pass beyond the stricture. Therefore, a small incision was made in the lower abdomen, and the terminal ileum was brought out of the peritoneal cavity. Obvious fecalization of the proximal dilated segment was noted. This part of the bowel was then emptied, and that segment was resected, and side to side primary anastomosis was carried out. The resected specimen was retrieved in an endo bag, and hemostasis was secured. This patient made an uneventful recovery following surgery, and 3 days following surgery, she was discharged home in a stable condition. Thanks for watching.